Good evening, everyone, and welcome to this virtual panel discussion on Catch It Early, Make a Difference, Raising Awareness on Oral Cancer. I'm Amrita, your moderator for the evening. I'm honored to present an important discussion on oral cancer in collaboration with Merck. As we all know, oral cancer is one of the most common and also one of the most preventable cancer in India. But the sad part is awareness about the oral cancer is low. Today we have experts from oncology and advocacy to discuss prevention, early detection, and treatment strategies. I'm pleased to welcome our esteemed panelist, Dr. NVS Ramakrishna. He is Senior Consultant and HOD, Medical Oncology, Bakshi Sri Sankara Cancer Center. He is Medical Oncologist, Max Hospital, Gurgaon, and Max Super Specialty Hospital, Saket, New Delhi. We have Dr. Manish Jain, Director, Medical Oncology, Ruby Hall Clinic, Pune. We have Dr. Viswanath S. He is Senior Consultant, Apollo Cancer Center, Bangalore. We have with us Dr. K. Madan Gopal. He is Advisor, Public Health Administration, NHSRC, Ministry of Health and Family Development of India. Amar, Senior Consultant, Niti Aayog. We have with us Dr. Urvasi Prasad. She is public health and policy expert. She is also ex-director at Niti Aayog. We welcome to our all panelists. Now let's begin our conversation. So Dr. Ramakrishna, let's begin with you. India continues
in that 55,000 cases are deaths are occurring in India. So tobacco chewing is the most important a contributing factor, and eating betel nuts also very important in our, especially in Orissa belt. We see a lot of cases eating betel nut and cigar smoking. One of the important contributing factor. So in our belt of what we practice daily, this thing.
Thank you, Dr. Ramakrishna. That clearly shows why early screening, awareness, and reducing tobacco use are so important in tackling over cancer in India. So, Dr. Chup, over to you. What are the earliest signs and symptoms of oral cancer that people should be aware of?
So usually in Indian subcontinent, in Indian scenario, the oral cancers are much more. So when you talk about the head and neck cancers, it can be oral cancers and the oropharynx cancer, as in the front part of the mouth and the back of the mouth and the throat and everything else. So in Indian subcontinent, the oral cancers are much higher, and majority of us, almost 2/3 head and neck cancers are oral cancers, and usually are because of, as Dr. Ramakrishnan also said, it's also because of the habits which we have, the betel nut chewing, the tobacco chewing, and thankfully they're going down, but then they're still, in a certain social strata, they are still very common because of the routine lives which we have. So most of these, they end up presenting with a non-healing ulcer. They have a wound on the tongue, or they have a wound in the buccal mucosa. Most of these oral non-healing ulcers usually are there for more than 3-4 weeks. There are bleedings which happen during these, and there are obviously which pains happen because of them. So classically, most of them have a non-healing ulcer. This is usually the first sign, and that's the most common presentation which we have. The second most common presentation is generally the for the oropharyngeal and the laryngeal cancer. It's usually obviously the change in the voice which you have, and there is some difficulty in swallowing which you have. So those are the other early signs which you should be looking out for. But I think given the presence of what is the site of occurrence, because majority are oral occurrences, as I've told you, those are the signs. For somebody which is a little back in the nasopharynx, you'll probably have some degree of swelling in the neck. There'll be lymph nodes. So basically the crux is anything which is persisting for more than 3-4 weeks, you should definitely think of that it can be cancer, and you should always get it evaluated.
That's very informative. Thank you, Dr. Chu. These are signs people often overlook. So your explanation really helps in creating awareness. Dr. Jain, turning to treatment, could you walk us through the typical treatment pathways available for oral cancer patient today? Are you there? I think there is some technical glitch. So, moving life after treatment, Dr. Vishwanath, uh, what are some of the biggest challenges oral cancer survivors typically face once treatment is over?
Yeah, good evening at the outset. Thank you, ISW and Merck, for this opportunity. And so, to answer your question, Amrita, the journey of a patient with oral cancer starts right from the diagnosis, like Dr. Bhuvan said about the symptoms. Once a patient is diagnosed, the kind of denial and the kind of emotional turmoil they face, not only the patient but also the caregivers and the family. Right from there it starts, and then subsequently, if the patient undergoes surgery, then post-operative complications, and then chemotherapy, radiation, the complications associated with that. And then when we talk about survivorship, there are a lot of challenges which these patients face. It's mainly the speech and swallowing difficulties, and the facial disfigurement which they have, and the kind of social stigma they face. And they also tend to communicate much lesser as compared to others because of this social stigma, and then the chronic pain. And then not only that, the body image issues. There's so much of disfigurement which they have this body image issues. And of course, the kind of self blame and that guilt, that probably because of their they were tobacco chewers or alcohol, that the blame, which the blame game which starts. Not only that, it's also about the economic burden. The economic burden is huge. What we call as out of pocket expenditure in India, 50% of our patients pay out of pocket and are so expenses is huge, and the financial toxicity is also huge. Overall, if you look at the survivorship, it is quite fragmented in India, and there is a lot of unmet need in this area where the survivorship, everybody has to come together. Not only the medical oncologist, the surgeon, radiation oncologist, and then the nutritionist, and then the psychosocial workers, the psycho-oncologists. Everybody has to come together for drawing out a plan for these patients for a good survivorship.
Yeah, that's such an important reminder. Thank you, Dr. Vishwanath. The recovery phase often gets less attention, but you said it's critical for overall healing. So, Dr. Gopal, looking at the awareness side, what do you think? Public awareness about oral and head and neck cancer is still low in India. So, what's your opinion in that?
Dr. Amrita, it's not an opinion, it's a fact. Because as I was listening to my previous panelist, they have rightly mentioned about the awareness. You first start with the head and neck, because the whole topic is about the head and neck cancers. You have to see that how these head and neck cancers are detected. First is bringing the people to the system, and then once they are into the system, they should be so much aware that yes, they are having some problem, and they need to consult the right person for getting the things diagnosed. That's a tricky issue which is there. But having said this, you should first understand the level of work which at the government level which we have been doing. If you look at the infrastructure which has been developed, so right, I would be talking about the private sector, public sector infrastructure, because we do have around 18 lakh beds, of which 50% are coming from have around 2,10,000 health facilities, right from your Aishman Arogya Mandir to district hospitals. And most of the district hospitals, they are now been getting upgraded into medical colleges. That facilities are there. At the peripheral most level, you are having the sub-health center, erstwhile sub-centers, which are now being rechristened as Aishman Arogya Mandir. This is the first contact. That means we have envisioned that these centers will be providing around 12 set of services, Previously, sub-centers were providing the RCH focused services. Now, we have included the screening for cancer. Right now, we are focusing on screening for cervical, breast, and the oral cancer. That means head and neck cancer is more or less in the radar for the screening of the population. That's one thing. Second thing is how to bring the people to this centers, because we do have around 170,000, 1,70,000 facilities. How to bring them to this? I'm talking about the primary level thing, not the secondary and tertiary where the experts are sitting. How to bring the people so that based on the checklist, based on the visual examination, based on the symptoms and other things, they can be referred or connected to the higher centers for the diagnosis and treatment. That's the second thing which needs to happen. That means through this Ayushman Arogya Mandir, the primary health centers and the community health centers, we are trying to bring the people in the outpatient as well as through outreach mechanism. If you look at the way the things happen in the public sector, that means we do have outreach sessions on a regular basis. Each Ayushman Arogya Mandir caters to around 5 to 6 villages. That means essentially covering 5 to 10,000 population. Outreach activities happens through the auxiliary nurse midwife ANM, which popularly known as, or the ASHA workers. Feedback from the, and this information is analyzed and they are brought to the system. Once they are brought to the system, it's up to the people if they are not able to present, because one of the important thing is the information asymmetry is there in the country. People are there with loads of information, but there are people who are having problem, but they are not able to articulate and express themselves that they are having the problem and for seek treatment. The moment they see a doctor, they forget that for what they are seeking the treatment. This has happened to you. It has happened to me. It can happen to any of the people. They say that I will be going to the hospital and talking to the doctors about this thing, and after seeing other thing, they will talk about something else, and they will talk and seek treatment for something else. So that's is one is the information asymmetry. Second thing is how to articulate your problem. That's the real challenge lies. Creating awareness has to address these two aspects. That means one is addressing the information asymmetry, and second thing, how to make the people through interpersonal communication, behavior change communication, to articulate their requirements. We have been pushing for breast examination. That's I'm just citing an example before we can talk about the head and neck. As my previous speaker have mentioned that if you are having a wound in your tongue, in your oral cavity, how many people are conscious about that? With tobacco consumption, chewing tobacco is a big problem in the country. It's not the smoking form of tobacco. It's a chewing tobacco which is the problem. With a cohort of around more than 25 crore people who are chewing tobacco, if this kind of awareness is not there, when to seek treatment, if they are having thickening of their mucosa, if they are having any blister is there, any ulcer is there, and they are having any change in the voice, they need to immediately see that. So that's one thing. That means you have to see that how the information asymmetry as well as the motivating the people to come forward and seek treatment. That's another thing. We can create systems. We have already created a system, and through that systems, how people will come, how people will use it. That's another challenge we have if you want to bring the awareness. For the awareness, apart from the health system, there are other people who are also working. Here comes the role of the community level organizations who are working there. They have to bring the people, because if you look at the ASHA program, they are the bridge between the community and the system. That means they are bringing the people to the system and getting themselves team. Then the other question will come that I am bringing the person to the system and you are not able to screen it. Then here comes the role of the technology. That means most of our centers, they are enabled with e-Sanjeevani. That means the largest teleconsultation platform which is available in the country. That is e-Sanjeevani platform. And every day, more than 5 lakh consultations happen. That's a big number. It's not a small number. That means a patient walking into any of the centers, if the health worker or the staff nurse who is posted there, if they are not able to understand, they will just connect with the doctor sitting at the district level or a higher center or a medical college and seek their opinion through a video call, and immediately a prescription is also generated through this. Either the person is to be referred to the higher center. If a person is to be referred to a higher center, this mechanism do exist for interfacility transfers of the patients. And we have to remember that most of the services in the government sector is free of cost across the country. Some of the places it would be a user fee. Even you and me can go to the government institution and get ourselves treated free of cost, provided we can wait for our turn for the examination, for the investigations and other things to happen. If you are having patience and time, you can always walk in there and you also can get treated. Your question was about aware about this kind of facilities available in the government sector. No, the answer is no. You will say that primary care, kuch nahi. Primary care is not OPD care. Many of our providers, they are also not aware that these kind of facilities do exist in the government system. And what about the people who are not that exposed to the information? Information asymmetry is there. That means if a person walks in with a problem of your difficulty in swallowing, blisters in the mouth, and the thickening of the mucosa, wound in the mouth, or there is discharge in the ears, so that means in the arm centers, we are trying to see that the ENT services are provided, the oral services are provided. And apart from that, wherever we are not able to reach, we are extending and outreaching the places through the mobile medical units. That means we are trying to bridge whatever things are there. And now we are also bringing in the private partners to at least partner with the government programs so that if we are screening it, we can screen and we can't be providing the tertiary level and the advanced form of therapies. If somebody is requiring that, a partnership models is also evolving. You see the partnership, the hub and spoke partnership models which are there. And taking the success of this kind of models, I think in this budget speech also, you have seen a provision for daycare cancer center. They will essentially work on this hub and spoke model so as to address the requirements and needs. As mentioned by one of the panelists, saying that the out-of-pocket expenses. Yes, out-of-pocket expenses needs to be there because if a cancer happens in any family, the family goes down economically by at least 10 to 20 years. That kind of catastrophe is there. Then the government is very much conscious about this fact, and we are trying to see that how this is also avoided, so that the travel time to the higher centers, they have to continued at the district level in a spoke model, so that things happen. And this is happening. That means that this concentrated efforts are being put in, you see that some of the states they are being able to screen the population, 90% of the eligible population. Take the example of the women for screening the women for cervical and the breast cancer. They have been able to do that. And similarly, with with national oral health policy coming in, you will see that how this neck and head and neck this cancers will take a quantum leap because the policy is there. It has been already been discussed, and I think they are in the process of releasing it. The draft is already final, and you see that when the data starts coming in about the head and neck issues and aspects, you will see that how quickly the important aspect which you have mentioned about creating awareness about this thing. Apart from that, another thing before I close, I think I should be answering all these things so that I can. I was in a call. I thought that my turn would be coming around 7:30 plus. But since you have asked this question, let me say that one of the important things about raising awareness is to identify survivors, to share their experiences because they will be helping the other people to come forward and taking the message that the early detection is the key for having a good quality of life, even if a person is directly with cancer. That means a lot of efforts are there, mechanisms are there, system is there, infrastructure is also built around that. In the private, you are having biomarkers, you are having all the things. You name anything, that kind of facility would be available in the private sector. See that how we amalgamate both the things and make a win-win for all the people. But the important thing which lies is the awareness, and seeing that people should come to get themselves examined. Even after examining, we should be having a good capacitated personnel who can do good counseling and provide good guidance how the treatment will go on. Even if the good guidance is given, we should be having capacitated medical officers and the medical team to at least who can take a call that what kind of treatment modality is to happen for that particular person. I will stop here in case the time permits. I will come back again Okay,
Yeah,
thank you very
sure,
much.
sir. Thank you, Dr. Gopal. You rightly made a powerful point. Without open conversation and strong public messaging, we risk staying silent about something that needs urgent attention. So, Dr. Urvasi, coming to you, what specific efforts are needed to improve access to screening and early care in remote or underserved areas? Over to you, ma'am.
Yeah. So, when you talk of access to screening, obviously there's, demand and supply side factors at play. So demand is, has been talked about a lot in terms of creating that awareness, but awareness, not just generic awareness, but making people aware of specific early signs and symptoms that they can actually identify potentially even themselves as at least worrying signs that need to be investigated. So what are those early signs and symptoms which might be more specific to the disease? They could also be some generic systemic things like you're losing weight or you're losing appetite or things like that. So these are things that can happen in somebody for hundreds of different reasons, and so it's very difficult sometimes for a patient to understand that at what point do I have to get. So I think awareness in a very tailored way, not just kind of general awareness, because that might not be as helpful. Then, of course, making the case that coming early to the health system is always better than coming late. A lot of people, because of stigma, because of fear of losing their daily wages, if they get a cancer diagnosis, how will we get treated, where will we get treated, these are all very real questions for the majority of Indians still. So therefore, making the case to them that, still, if you come in the early stages, it can be much easier to treat. You can be cured also fully. You can also cut down on your expenses. And I think this point can only be made if we have stories of people, which are very relatable. Because I see this a lot in the cancer space that we're constantly talking of celebrities. And, celebrities are not people that the common person can relate to, frankly. Celebrities can get the best of treatment in India, abroad. They have all the, resources at their disposal. So I don't think they are the best example. They can help to break stigma. It can help to break stigma that, if a celebrity is also talking about it, then I can also talk about it. But in general, I think the relatability of a celebrity is, I think, to 97, 98% of the country, it's virtually not there. So it's important that, when we talk of awareness, it is people who people can relate to. Those are the people we need to be talking about. So I think that is what I would say on the demand side. On the supply side, I would say that yes, we do have screening which is supposed to happen at the health and wellness centers, which are now called the Ayushman Arogya Mandirs. But of course, every state, there is a lot of difference in implementation, and that's true for all kind of policies and programs, because health is at the end of the day a state subject. So implementation really comes down to the state sub-state levels. So how diligently are we doing the screenings, and not just doing the screenings but also the referrals, because there's no use screening somebody, but if they are then not referred to the next level of care, if they don't receive the proper care, then that screening is meaningless. So that is what we need to really be very, systematic about. And that is obviously difficult in a country like India. We are so large, we have so much diversity, but ultimately we have to ensure that if something is in the guidelines of primary health care, it should be delivered, as it is stated on paper. So I think that is very important on the supply side. And also, I would say training of the human resource, because, we've spoken a lot about human resource here, and people come to the health system at different levels. Like in breast cancer, cervical cancer, we always say that it's probably that a woman would have come to a gynecologist, and that would have been the first time that she's come to the health system. And there's a chance to, pick up on that early sign or symptom and then refer her to a gynae oncologist. So similarly, I think here also, people might come to a general physician, people might come to a health worker, ASHA worker, or anybody, right? So everybody needs to have that at least basic knowledge that, okay, what, if I'm not sure or if I'm uncertain, how do I refer? Who do I refer to? So I think that kind of training capacity building is also a very ongoing initiative that is much needed, because it's important in a heterogeneous health system that everybody has at least that basic level of awareness. So these are some of the things I would say, on supply, on demand, to really improve our screening and early detection.
Yeah, thank you, ma'am. That's a really very grounded view. And reaching the last mile is absolutely vital if we truly want to reduce the burden of the last stage diagnosis. So, digging deeper, Dr. Ramakrishna, how significant is the role of tobacco and smokeless tobacco in driving oral cancer prevalence? Over to you. Dr. Ramakrishna, sir, are you there? Now, moving ahead, Dr. Chug, are there any specific check methods that people can use to spot early sign of head and neck cancer? So, what's your view in that? Oh, there is a message from that there is some OPD emergency from in his hospital. So, we are moving to Dr. Vishwanath. Sir, how important is psychosocial support in the recovery process? And do we have a structured program to address this?
Yeah, so just like the previous panelist mentioned, I think what the patients with head and neck cancer go through is very, I would say, it's a big turmoil for them, not only for the patient, but also for the caregivers and the entire family. And if you look at the kind of just to quote some numbers, around 45 to 50% of our head and neck cancer survivors will have some kind of psychological issues, including depression, some kind of post-traumatic stress disorder, fear of recurrence, and that anxiety which is perennially present in them. And like in your question, you did mention that we don't have a formal psychosocial support in all hospitals. It's a spectrum. So there is a major urban-rural divide. If you ask about any patient, if you ask any patient in the rural setup about psychological support, I'm sure they will not be knowing anything about it. But there are hospitals in the urban setup where there is a formal, well-organized psychosocial support, oncopsychology teams who work with these patients to address these issues. So it's a big spectrum, but and there's a major unmet need here. There is some work going on in Tata Memorial, including RCC Trivandrum and certain other centers, regional cancer centers. I'm talking about the public space, where they're trying to create a formal psycho-oncology support, which can go a long way in addressing these issues and maintaining the, I would say, the emotional quality of life for these patients.
Yeah, that's so important. Thank you, Dr. Vishwanath. And mental and emotional support should go hand in hand with medical treatment. And I'm glad that you emphasized that in your talk. So, Dr. Gopala, how can we involve young people in this mission to promote healthier habits and preventive messages? Dr. Gopal, are you there? Ma'am, what's your view in this question?
Sorry, could you repeat the question?
Yeah. How can we involve young people in this mission to promote healthier habits and preventive messages?
Yeah, I mean, I think it's always best to start young. In fact, if we start with children, it's actually ideal because that's when habits are really getting formed and people's lifestyle foundations are being laid. So I think schools is a very, very good opportunity. Of course, even earlier, in the family, in the household, but it might not be possible there always for different reasons, because people belong to different kinds of families, households. There's different kinds of stresses. Parents might not have themselves had exposure to those kind of issues. So it's not always possible, and hence school is a very good place. Then, of course, even moving ahead to colleges, universities, wherever you have young people. I think now, of course, social media is there, but social media has its pros and cons. It has to be used in the right way. But it can be a very good way of engaging young people at scale. So I think, we have to raise of course, awareness about better lifestyles, about avoiding tobacco, avoiding alcohol, exercising, limiting your, say, red meat content in your diet, or, things like that. So I think those are basic lifestyle things we can, of course, talk about. But also the stigma aspect, I think, needs a lot of addressing. The aspect of cancer, I think that is still a very neglected thing. I mean, I'm somebody who's living with cancer myself, so I can say that I had to advocate for it, myself. I had to say, look, this depression is going to probably kill me before the cancer does. So we have to do something about it, right? But everybody can't really advocate, or they feel hesitant, or there's stigma, or there's shame. How can I even use this word depression, or how I have to always be positive. I find this a very annoying thing with a cancer diagnosis, that even normal human beings are not always positive, but cancer patients are always expected to be so positive and upbeat. And I think at this, then what it does is it kind of ignores the real issues that they might be going through, whether it's anxiety, whether it is trauma, whether it is depression. So I think we have to also use young people to normalize conversations around these things, because young people might be more amenable, as compared to older generations where the stigma of some of these things was higher. So we can really use young people, make them a powerful voice, that this is, you don't have to always be dancing up and down and being positive and upbeat. And if you have an issue with your mental health, it's okay to talk about it, it's okay to seek help. There's no shame in that. Because ultimately human beings, physical mental health is very connected. It's not like it's two distinct parts, and it doesn't matter. So if your physical health is so bad, if you've got a cancer diagnosis, which is something so serious, your mental health is almost naturally going to be impacted. It'll be very strange, in fact, if there's no impact, at all on your mental health. So let's normalize some of these things, and that's why I said, instead of celebrities, let's have ordinary people, let's have people about these issues, how they've dealt with them, how they've come out of them. That, I think, can be far more impactful than some very unreachable, unattainable celebrity, kind of talking about these issues.
Yeah, thank you, Dr. Urvasi. As you mentioned, involving youth is such a smart and long-term strategy. They are also the change maker for tomorrow. So, as you mentioned that you are also a survivor, so your perspective holds a unique significance here. So, according to you, how can survivors and the media work together to break the stigma and the encourage public for open conversation?
Yeah, I think like I said, there's a huge role to play, because when somebody comes out and says, I'm living through this, then I think it makes it easier in general for other people to also talk about it. But like I said, relatability is very important. So maybe middle class will relate to me, but maybe somebody from a poorer family might still not relate as much to me, right, as they might to somebody from their community. So I think having that relatability in the survivor stories, the patient stories is very important. And then I think encouraging, like I said, open conversation. And of course, media can play a role in this. Not just mass media, but even, more local media, different kinds of media channels that we can use to normalize conversation, and to say that it's okay to talk about these issues. It's okay if you've got a cancer diagnosis and you have been a tobacco user. It's okay, now you don't have to keep living in that guilt that, oh, it's all my fault and, I should be ashamed. Okay, that's done, right? Now you move forward. So I think those are things that we need to convey to people, because otherwise, I worked a lot in the TB space. And again, it's a space which is highly plagued by stigma, and I've literally heard patients say that, we'd rather die than have anybody know that we have TB. So I think similarly, we need to tackle this. We need to tell people, look, there are treatments. The earlier you come, the better they are, the more affordable they are, the less complex they are. So I think survivors need to be, in this way, their stories need to be used and, of course, disseminated at scale by the media. That's where the media can come in, is to bring in the scale. But I would want it to be a very regular thing. Like IHW Council does. I would compliment you guys. You always do it on a very regular basis. A lot of other media efforts are very one off. When there's World Cancer Day, there'll be this whole, series of things happening, or there'll be a particular month. But then after that, we kind of forget about it. And cancer awareness is hard work, it's constant work. It cannot be a one off. So my only thing would be that whatever we do through media, through communication, let it be a constant outreach effort, because these messages need to be constantly given out to people. Only then, can we see some, the needle moving in terms of behavior change, because it's not easy. It's not easy for people to change their fundamental behaviors. And so just one campaign or one messaging is not going to do it. It has to be a repeated thing, just like you guys do. So, compliments to you on that.
Thank you, ma'am. And beautifully said. Survivors' story are not just healing; they are the power of change in shifting public perception. Now we deep dive into detection care support. So moving to Dr. Jain is there. Sir, can you hear us?
Yes.
Yes, sir. Welcome you, sir.
Thank you.
Sir, from your perspective, are the current treatment methods effective in improving the survival and quality of life?
See, before I go on to that, I would just say that, I heard all the previous speakers, and I would say cancer is the most preventable disease, and it can be prevented. If we just take away smoking, 85% of lung cancer will be gone out of this world, and which is 25% responsible for death in cancer. So it's all about awareness. The problem is that we are not up to that mark. We are not either up to the mark of detecting it early or making people aware of that it can be prevented. Having said that, what was your question? And the second point I wanted to make was, we do involve every patient in our institute at Ruby Hall is being seen by a psychiatrist. So we do give importance of mental health, because I would say all the outcomes are linked to our mind. So if you are bigger than your problem, you will always win. And I would like to ask, like, what was your question? I didn't get that.
We were asking, are the current treatment methods effective in improving survival and quality of life?
Yeah, definitely. We have quite effective methods from the time I started in oncology in 1995 and today. We definitely have such a big change. And I would say the patients are doing extremely well. your cancer, whether it is head and neck or any other cancer, immunotherapies, targeted therapies, and the care, what we have achieved is significantly higher than what we had earlier. Earlier, we used to say that, if you have got a diagnosis, we used to just say that you have 3 months, 6 months, 9 months. Now we are talking of years, and patients sometimes are getting cured. Head and neck cancer, 60-70% in advanced stages are getting cured. In metastatic setting, we have immunotherapy causing 20% patients cured. So there is a significant change. But yes, the thing is, what we want people to be aware of is that, people are not being treated rightly. So dosaging is an issue. Like cisplatin, if you are using it in head and neck cancer, then recommended dose in concurrent setting is 100 per meter square, but very few centers are using that dose. Most of the patients are being treated suboptimally at lower dose, not treated in a particular format. Like, you need to be aggressive, don't have to give gap or space to your opponent. So your tumor gets a space if you don't treat it in time. So treating it in time, giving right dosaging, motivating them, supporting them for their complications, giving them rise to feeding, getting all your supportive care up, nutrition, uh, rehabilitation should go hand in hand. So it's not like palliative care after the patient is terminally ill. Involve your palliative care day one. So that is very important. And only then you can make your care superior. You can let the patient flow through the treatment very easily and complete the treatment in time and achieve great results. So my suggestion is that it's a teamwork. It's not like I do my job and then I give it to somebody. I involve that person right in day one. So if there is an ENT requirement, I get them involved. Should come in quickly. The rehabilitation should be a nutritionist. Everything should be involved as early as possible.
Thank you, Dr. Jain. That reassurance about treatment outcomes, especially when combined with early detection, makes a strong case for timely intervention. So, Dr. Vishwanath, what kind of nutrition and rehabilitative support should be offered to survivors as a part of comprehensive care?
Yeah, so the nutrition support for patients with head and neck cancer should start right from the time of diagnosis of this particular entity. So this is called prehabilitation. So right from the beginning, we know that these patients have to undergo surgery and then chemotherapy, radiation, especially when they undergo chemotherapy and radiation. Radiation, as we know, causes a lot of mucositis, mucosal damage, causes a lot of dryness of the mouth, difficulty in swallowing. So we have to make sure that these patients are adequately nourished, and to help them get the adequate nutrition, we can use oral supplements, and not only that, there are a lot of patients who may find it very difficult to take orally. So we might have to resort to what is called as enteral nutrition, where we can put in a Ryle's tube, which is a nasogastric tube, or we can go for what is called as a percutaneous gastrostomy. It's called PEG tube. So with this, we can give adequate nutrition. And not only that, post completion of the treatment, also the patients will have these problems for quite some time. Like the previous panelists mentioned, it is important to get the swallowing specialist, the speech and language specialist, so, and make sure that physiotherapy is done well, so that all these just can also go a long way in improving the overall nutrition for the patient. The patient is able to swallow better and taking care of the nutrition, and also certain other supplements. There is a lot of data about giving amino acids and whey protein, and all these things can go, and getting the dietitian involved from day one. So onco-dietitians who are experts at this. These are a few thoughts, and apart from that, rehabilitation measures, like I think, like the previous panelists very clearly mentioned, getting a proper speech and language therapist, swallowing therapy is important, physiotherapy is important because they go into a lot of trismus. So make sure that adequate exercises are done, and occupational therapy, and not only that, exercise. Your exercise is quite vital for these patients. Making sure that they do a lot of aerobic exercise, And there's enough data in other malignancies as well, like colorectal cancers, and even some data for head and neck cancer patients, that exercise and nutrition go hand in hand, and it can improve the overall quality of life, which has been documented in certain studies.
Thank you, doctor. You have made a vital point. Recovery isn't complete without strengthening the body and restoring confidence through proper rehab and nutrition. Moving to Dr. Gopal, as you already covered this question in your earlier speech. So how can the government and private sector come together to scale awareness and early screening initiative? Over to you, sir.
Okay, thank you, Dr. Amrita. Sorry. At that time, I had a call, so I had to go. You were calling my name, so apologies for that.
Okay, sir. Dr. Urvasi covered the point. Thank you.
Okay, that's fine. Second thing is, as I mentioned in my earlier statement, means awareness is the key. But how private people, they can also join in, because even if I create, just you have to understand as a common arithmetic, the burden is so high. Even if I create 1 lakh beds today, they would be taken up. Immediately after 3 months, you would be struggling to find that you have to create more beds. That kind of need is there. Second thing, as mentioned by my previous speaker, prevention is the key. If you are able to bring the patient early into the system, early diagnosis is the key. We have been talking since when I was doing my PG. Then also we used to talk about early diagnosis and treatment. In fact, that is true for all the diseases. The moment you are able to diagnose it with, but the modern medicine has now evolved to such an extent that with the advent of this biomarkers and the sensors and the other things, you are able to detect the disease very early, provided the person comes to the system on an early and seeks treatment. First, you have to start with raising awareness. Awareness means in case something is abnormal in the medical parlance, in the medical colleges, we have been taught that first to start looking at the normal things. Start looking at the normal. As a person is coming, just examine him and try to find out the normal things. The moment you are trained for finding the normal thing, immediately you are able to detect and pick up the abnormalities. The training has to be like that. It's not that we focus on the abnormalities and you will start overdoing things and you will be picking up abnormal things only. We should know that there are many common occurrences, there are very general occurrences, and even a small deviation from that, that kind of awareness is there. Suppose you take the example of the oral cancers. Means everybody's what is there in their mouth. In case of small deviation, they should know how to appreciate that, and that kind of awareness we have to build in right from the schools, because the tobacco consumption, though people will agree or not, right from the age of 9 years they are inducted into tobacco. And if you go down in the south where the population is the rice eating population, where previously because of the riboflavin deficiency, the people used to have raw red tongues. So you have to see that what is normal, what is not normal, what is nutrition related, what is abnormal, provided the people start looking at the normal things. The moment they look at the start, that means you have to create awareness of looking at the normal, what is the normal thing, and then in case of any abnormalities, they have to come to the system, the health system, be it a health worker in the form of a ANM or a medical officer at a PSC or a specialist at a CSC or upwards. They have to seek medical attention. If they are not able to come to that thing, a technology tool is also there and they can come. The main thing is bringing them to the system, seeing that some abnormal thing is there, and the things will automatically come forward from there. That means bringing early to the system, putting them on the early treatment. That's the key. Because previously we used to talk about 5-year survival rates for cancer patients. Now that is now turning out to be misnomer, because people are surviving beyond that. Because 5-year survival rate, we used to say that 10%, 20%, 80%. Now that is not there, because the diagnostics have improved, the treatment modalities have improved, and the personalized care has also improved. But the bottom line is how to bring the people by raising aware, village level. You have to find the awareness is the key. But what has happened to address this issue? So some of the state government, they have partnered with the medical colleges, the private medical colleges, and the institutes like Tata Memorial, Cancer Memorial Centers. They have partnered with the state governments, and they are helping the states in screening the population, raising awareness. After raising the awareness, either through the mobile medical units or to the IC campaigns run to a different mode, using the different folk media and the mid-level IC campaigns, they do it. They bring the people to the system. And in the southern state, in this way, they are able to screen the population, bring the people to the system. After bringing the people to the system, now you have to give an IC saying that even if you are detected with some abnormalities, you should not be afraid of seeking treatment. The second level of awareness efforts which we are doing with the help of the private is bringing them how to allay the fears of the people who are having cancer or who would be detecting with the cancer. Otherwise, they will not come for screening. You look at the screening for cancer in the country, in the Western countries, the screening for any type of cancer is more than 90%. Whereas India, you take the common screening thing, only 8 to 9% of the eligible population they are screened for cancers. You take the example of cervical cancer. That's an example. Okay, how much the awareness is there. Though these are fatal things, but people need to be aware that this is an abnormal thing. If an abnormal thing is there, they should come and seek treatment. One of the important thing which is happening, which you will also agree that the government-sponsored health insurance and assurance schemes, the PMJ and other things, they're changing the health-seeking behavior and pattern of the people. That means people going to the government institutions or any private institution, once they are going there are people, they look at the displays there, they look at the continuous videos which are being shown in the waiting areas. And obviously, if they are having anything abnormal, they used to seek consultation also. So the behavior pattern is also changing. That means a good sign is that people are now becoming more and more aware. Even if a small problem is there, they will get themselves clean and they are doing that kind of pattern is there. But nevertheless, a lot of work more is to be done when we go to the below district and sub district level. The real challenge is there. With a good connectivity, even if awareness is there, with a good motorable connectivity, they usually come to the district level and the block level for treatment. So what we are doing is with the partnership, we are trying to strengthen the facilities at that place so that if the screening happens at the lower level, they can come to this level and they are screened there. But this private sector partnership models, they are yielding good results. And as a result, what has happened? Previously, we used to struggle to screen whole of the population. Now, with their help, at least once we have been able to screen 90% of the eligible population in some of the states. So that kind of volume and the leapfrog, that kind of thing happens if we partner with the private sector. And taking cue from that, now more and more partnerships are there. Don't call it as public-private partnership. You call it as partnership for public provisioning. That means we are partnering for providing services. So a lot of examples we'll be seeing in the coming days. And a lot of philanthropic are there. Now you see the trend which is happening in the private sector. You are having a chain of private sector cancer hospitals. You are having chain of, suppose eye hospital, a chain of hospitals. So what they are doing, they all are serving to the same set of population. That's why collaboration and partnership will be the key for raising awareness, for bringing the people, for building capacities, as well as doing the early diagnosis and treatment for the cancer. Thank you.
Thank you, Dr. Gopal. As you mentioned, collaboration is indeed the way forward. When sector aligns, we can scale impact faster and reach those who need it most. So, Dr. Jain, how important is to have team of specialists working together when treating advanced or complicated cases of oral cancer?
See, it's very important, as I said earlier also, that you cannot treat a cancer without a team. And the team has to be with everybody, like it is the surgeon, the radiation oncologist, the medical oncologist, the speech specialist, the ENT, the psychiatrist, the nutritionist, psychologists, counselors, social workers. So it's a dentist. So everybody is a team, part of team, and you cannot say that without the team we can treat cancer. We can treat cancer. So my suggestion is that yes, first is the team. Second is like if you don't have anything like particular department, some departments don't have, some hospitals don't have radiation, so they may have to collaborate with other hospitals to get that radiation involved. And some of the hospitals I visit do not have radiation department, so the radiation person is called in tumor board in their department to discuss like when to start, who will get treated when, whether we are going to start with surgery or start with induction chemotherapy or directly chemoradiation. It depends on the stage of the cancer, the type of cancer. So these team works are important. Second is the referral pattern. See, whenever you have a particular, you need to have, patient comes to me as a medical oncologist, I cannot start everybody on chemo. So I need to refer it to the right people, plan it up, that what is the right treatment for the patient. And even whether it is referred to the tertiary center, there should be a proper referral. If I have to refer it to the dentist or to ENT or to psychiatrist, I need to have a referral pattern. We should have some people in between who are referring them, guiding them how to go about and when to reach there, because hospitals are so big, they may not even realize what time to come and what time to go. So we need to have proper set of information being provided to patient to mobilize them, the kind of financial support they need, the social support they need, the emotional support they need. We need to have people who will guide them with all those things. So I think everywhere we require a kind of caregiver, we require a person in between, and the doctor cannot handle everything. So see, basically the ratio of patient to doctor is not that good in this country. When I was in US, we had 150 oncologists in Boston alone. And so we don't have that many oncologists in Maharashtra also. So that is the kind of disparity that we have in India. Each doctor has to see 2 patients on his way home. Like even if I come down of the hospital, I'm still seeing 2 patients. So that is the kind of numbers we have to handle. So we need to have people who will take care of these small things so that we can dedicate more time to the patient care. So it's very important. Teamwork is more important. You can create a team of patients who have undergone treatment and use them as your caregivers because they've already gone through it. We used to do this at our few centers where the patients they were motivated and they wanted to be volunteers on their own. So there was no payment to be done. They came at their own timing. Somebody came at 10 o'clock, somebody came at 2 o'clock, somebody came at 4 o'clock, and we had a chain of people who could handle this. And they were all survivors. They came on their particular days. Some people came on Friday, some came on Wednesday. So we had people who could handle these situations. So we had breast cancer survivors. We have a team of breast cancer survivors, head and neck survivors, and they come and help the other people. They also motivate them. So it becomes easier for them that I've gone through it and now you can go through it. So there are live examples. And what we have, another thing is we also have certain people in our institute who will introduce them to another patient who has been undergoing similar treatment. So we have some people who take them around to the hospital, make them meet other patients. So that also helps them to go through the treatment very smoothly, and they feel comfortable. They feel comfortable day one. So these are few tips which I would suggest that people can use to make the treatment and patient's journey easier.
Yeah, thank you, doctor, for that. And I think when we come together, it truly enhances the patient outcomes and the confidence of the patient. So, Dr. Urvashi, any final thoughts on how we can strengthen access and quality at a system level? Your final thoughts.
Yeah, I think we've discussed, so many of the dimensions. I would just say that, to the point that has been made, that teams, and I think moving towards multidisciplinary care is very important. I think for some patients, it is today accessible but for some it's like it's a still that we could have even access to a psycho-oncologist, or we could have access to a nutritionist or a physiotherapist. So for not for everybody is that the reality today, and that is the direction we need to go in, because it is true that the doctor, the specialist cannot do everything, and anyway we don't have enough of them right now. But even if and when we do, it's not their job to be doing everything, or it's not their core competence to be doing everything. So it is important to have different kinds of professionals on the team, and even people who've gone through it. I think those are people, while they can't give professional advice, but they can certainly help other patients. They can guide them, they can share their experiences, share what worked for them, what didn't work for them. So I think definitely, and a lot of patients, survivors are actually very motivated to help others, because only when you go through that journey, when you walk in those shoes, do you know what it truly means. So you are always, at least I am always willing, and I know so many others who are always willing to help other patients, or even just share your own experiences. So I think definitely that should also be leveraged more and more, and we should move towards multidisciplinary care and not just putting all the spotlight on the oncologist.
Thank you. Now, as we are moving at the end of this show, and this has been such a rich and thoughtful conversation, I want to thank each one of our panelists, Dr. Ramakrishna, Dr. Bhuvanchuk, Dr. Jain, Dr. Vishnu, Dr. Madan Go, for lending your time, knowledge, and experience to this mission. You have helped us understanding the full picture from risk to recovery, and from awareness to action. Most importantly, you have reminded us that early detection can quite truly mean the difference between life and death. To everyone watching, let's take this message forward into our homes, workplaces, communities, and in our conversations, because awareness is contagious. And in this case, we can save many lives. On behalf of our organizing team and Merck, thank you all once again. Stay healthy, stay informed, and have a good evening. Thank you all.
Thank you.
Thank you.
Thank you, ma'am.